We're going to go ahead and get started. We're a small group, small but mighty this morning. We appreciate you all hanging in there to the last day. And I am thrilled to be closing out the ITTC sessions. We've had 3 of them over the last few days in this same time slot and same room, highlighting and sort of featuring our different ITTCs and their examples and use of the Water of Systems Change model. So we're thrilled today to be including our partners here, and I am going to first introduce Dr. Dedsy and Ovidio are going to be speaking. So I'm going to introduce Dr. Dedsy, who will be doing the presentation, and it would be great for those of you who don't speak Spanish, you should have your headphones. There will be translation available. So Dr. Dedsy Berbesi, who was the director of the National Observatory of Mental Health in Colombia from 2013 to 2014, and is the manager of the Colombia ITTC. She is the dean of the nursing faculty and a research coordinator at the medical school at CES University in Medellin, Colombia. Her research spans the epidemiology of drug use, social networks, and HIV/HCV prevention, with extensive experience in population studies in Colombia. Dr. Berbesi is the principal investigator of a study on risk behaviors in people who inject drugs in different cities, and the principal investigator of a prevalence study of HIV and HCV in people who use drugs. So, welcome. Thank you.
Thank you. Muy bien, vamos a contar la historia de Colombia, del ITTC. Lo hemos denominado la importancia del lobby y la advocacy en el impacto de las políticas públicas. Y quisiera empezar con una frase que escuchaba ahora, un poco diferente, pero que va a lo mismo, y es como la ciencia no es suficiente si no incluimos la influencia política. Creo que esa es una muy buena conclusión para lo que nosotros hoy queremos presentarles en la experiencia que hemos hecho en Colombia y cómo hemos incluido como base fundamental el lobby y la influencia política para el desarrollo en el año y medio que llevamos con el ITTC en Colombia. Esta presentación la haremos también con el Ovidio Muñoz, quien en este momento está como director. Yo soy la manager de la ITTC para Colombia. Además de eso, nos acompaña un grupo. Un momentico, vamos a arreglar acá algo. Sorry. Sorry. Ok. Entonces estamos con un grupo de trabajo en el ITTC de Colombia y tenemos entonces expertos en el área de epidemiología, en el área de investigación, en el área clínica, pero en especial cómo hacer el advocacy. Nosotros lo hemos entendido como hacer entonces esa influencia en los medios. Tenemos un comunicador que nos apoya bastante en algo que nos ayuda bastante en Colombia, que ha sido el Free Press, cómo entonces influenciar en los medios de comunicación, cómo ser visibles. El ITTC lo empezamos el año pasado en tener esa marca de ITTC y que los ministerios nos reconocieran entonces como apoyo para ellos. ¿Qué es lo que entonces esperamos para el día de hoy? Que quede claro, y la invitación que también queremos hacer a los otros ITTC. Primero, la importancia que tiene el lobby y la advocacy en todos los ITTC, pero en especial en algo que hemos empezado fuertemente este año, y es cómo hacer el cambio de sistema, es decir, cómo pensar que el ITTC va a apoyar ese cambio de sistemas en cada uno de los gobiernos donde nos encontramos. Y lo segundo es todo lo que hemos compartido de los ITTC toda la experiencia de este encuentro que nos permite también poder entonces entender las demás experiencias, pero que también se vayan con un mensaje de que en Colombia hemos trabajado bastante en esa influencia política y que estamos convencidos que es un primer paso para ese cambio de sistema. Contarles un poquito de ese contexto en Colombia, cómo ya, y lo hemos escuchado bastante en esta semana, lo que sucede en los países y los recursos que logramos encontrar para la reducción de la demanda de drogas. Es decir, en las acciones de prevención tenemos, no es la prioridad, uno hay, y allí están los recursos, pero adicional a ello necesitamos que esas acciones y esas medidas que se tomen tengan en cuenta ese contexto político, social y económico. Y otro de los aspectos, y también es algo que es similar en muchos países, es que somos un país también multicultural, con unas también etnias diferentes, y que en este nuevo gobierno de Colombia se ha intentado llegar a otras áreas, y nosotros como ITTC estamos acompañando ese proceso tanto para el Ministerio de Salud como para el Ministerio de Justicia, es decir, que se logre llegar a esas regiones mucho más apartadas y diferentes, especialmente con estrategias que puedan acercarse a estas comunidades. En ese contexto, cuando este año empezamos a hablar de ese cambio de sistema, en Colombia nosotros ya veníamos trabajando sobre todo en ese primer triángulo mucho más pequeño, las políticas, es decir, veníamos pensando en cómo podíamos apoyar. El año pasado tuvimos la oportunidad de acompañar al Ministerio de Salud en todo el trabajo de cómo llevar entonces, cómo pensar la política para Colombia. Tenían que sacar esa política en el nuevo gobierno, y desde la ITTC nosotros acompañamos las mesas de trabajo, acompañamos, lideramos. Obviamente era una tarea del Ministerio de Justicia con el Ministerio de Salud, pero el ITTC siempre estuvo allí presente. Adicional, desde ese enfoque, y como les decía ahora, la ciencia no es suficiente. Ayer nos preguntábamos por qué las universidades están interesadas en los ITTC, porque siempre hacemos investigación, siempre estamos haciendo apropiación social, pero cómo logramos que eso que sabemos que sirve se pueda aplicar en las regiones, y para ello necesitamos hacer la influencia en política. Asimismo, algo que nos ha permitido el ITTC es fortalecer las relaciones y conexiones. Con ese denominado comité asesor, nosotros hemos logrado tener entonces también las relaciones con las diferentes instituciones. Eso hace entonces que la formulación e implementación de políticas y los programas también requieran esa presión y esa persuasión para las acciones que se van a tomar. Contarles entonces un poquito de las experiencias que hemos tenido. Algo que nos ha funcionado bastante es la estructura y el diseño y la sacada en puesta de policy brief. Esos policy brief son documentos que tienen una evidencia que es para los tomadores de decisión. Ya hemos sacado entonces el específico en política de cómo debería tener entonces la política de salud mental y drogas para Colombia. Sacamos otro que tenía que ver con el tema de fentanilo para Colombia, cómo estábamos en ese momento, y actualmente también le hemos hecho bastante difusión a la norma, y primero qué pasaba con el vapeo en Colombia, un poco las recomendaciones que desde la ITTC estábamos haciendo. Y pareciera como que los webinarios los hacen muchas otras agencias, pero estos webinarios y estas acciones de discusión están más pensadas en cómo los gobiernos departamentales o las regiones, por decirlo, y la parte local pueden llevar a cabo las intervenciones. Entonces es la reflexión sobre la necesidad de tener recursos para monitoreo y evaluación, y que tengan en cuenta esas prácticas basadas en la evidencia. Asimismo, nosotros hemos participado, y pues yo sé que está en español ya el documento, pero ahí ustedes lo que leen en la segunda parte es la posición del ITTC de Colombia. Es decir, no es porque estemos trabajando con el gobierno que vamos a hacer lo que el gobierno diga, sino que nosotros como científicos, como investigadores, como parte entonces de una universidad, les dejamos la mejor evidencia disponible, estamos allí en esa influencia de política, pero también colocamos la posición frente a lo que la evidencia está diciendo. Entonces esto es bastante valioso para el país. Asimismo, este año ya llevamos desarrollados varios cursos online que ustedes dirían, pero hay muchos cursos online que se están haciendo. Sí, pero este es diferente porque con los ministerios y con las demás agencias revisamos qué es lo que realmente se necesita, dónde no se están repitiendo las acciones para que se puedan llevar a cabo. Entonces, esto es algo en lo cual nosotros ya estamos pensando hacer la adaptación de los currículos universales, porque tenemos esa formación para Colombia, todavía ninguna universidad ha logrado esa certificación y lo queremos hacer es desde el ITTC. Ahora voy a introducir al Ovidio Muñoz como director para que él nos cuente un poco más en detalle cómo hemos visto ese cambio de sistema y los ejemplos que tenemos en Colombia. Gracias.
Buenos días. ¿Cuánto? ¿5 minutos tengo todavía? ¿Sí? Vale, muy bien. Entonces, yo les propongo un ejercicio. Bien, imaginémonos que hace aproximadamente 4 años atrás comenzaron nuestros niños, niñas y adolescentes y nuestros jóvenes a vapear en diferentes escenarios. Vapear en el aula de clase, vapear en los pasillos, y esta situación contrarrestaba unas fuertes políticas en prevención al tabaco. Mientras que reducíamos en Colombia las prevalencias de consumo de tabaco, comenzaron a aumentar el consumo de vapeo, pero no solo en niños, niñas y adolescentes. Pensemos también que grupos poblacionales que históricamente no estaban usando tabaco comenzaron a utilizar estos dispositivos electrónicos. Como ITTC encontramos un problema que había que comenzar a intervenir. Y comenzar a intervenirlo a propósito de la estrategia de las 6 condiciones para el cambio. ¿Y qué fue lo que comenzamos a encontrar? Que a nivel de representaciones mentales, el vapeo para estos jóvenes estaba dándose bajo la lógica de menos dañino que el tabaco. Sustancia no tan adictiva, sustancia no tan problemática, ¿sí? Y para los adultos, dispositivo que me ayuda a disminuir el consumo de tabaco. Y ahí teníamos un nicho de una serie de personas que encontraron fácilmente un lugar donde se acomodaban y podían aumentar incluso consumo. Entonces comenzamos a encontrar que adolescentes en un día 300 puff, ¿sí? O sea, estamos hablando de un consumo alto y fuerte. Pero no solo eso, consumo en cualquier sitio, en cualquier espacio y con cierto nivel de legitimidad. Algo así como, si no tenemos leyes, si no está regulado, está permitido. Y en ese orden de ideas, como ITTC, comenzamos a mirar qué teníamos que hacer, con quién teníamos que encontrarnos, cuál era nuestro papel para pensar esa situación. Y entonces entendíamos que como productores de conocimiento basado en evidencia, teníamos que ser los llamados a invitar y a encontrar a otros actores que estuvieran pensando en el tema. ¿Van? Y ahí aparecen los policy brief, documentos con directrices claras que, a pesar de lo limitado de la evidencia hasta el momento, nos permitía decir no estamos de acuerdo con esto. ¿Van? Y nos permitía decir tenemos que proteger a nuestros niños, niñas y adolescentes, y esta es una medida de prevención urgente. Y a la par de eso, comenzar a posicionar en los medios de comunicación. Entonces sacábamos prensa, ¿sí? Sacábamos televisión, noticias en las que mostrábamos lo problemático de la situación. Y eso llevó a que nos vinculáramos rápidamente con Ministerio de Seguridad, Ministerio de Salud, y a empujar también las iniciativas de ellos en la construcción y ampliación de la política antitabaco. Y emerge para este año la Ley 2359. Y la Ley 2359 es una ley que expande en Colombia la prohibición y la regulación del vapeo. Ahora con esa ley, ¿qué teníamos que hacer? Teníamos que comenzar a presentarle la ley, a hacer difusión de la ley. Y ahí aparece todo lo que tiene que ver con dinámicas de poder. ¿Quiénes son los grupos de influencia y a quiénes logramos contactar? A los medios de comunicación. ¿Sí? Para decirles que en una semana invertimos 11 millones de pesos, que, ¿cuántos son? $3.000, ¿sí? $3.000, solo en piezas publicitarias para salir en medios de comunicación. Pero no lo hacemos con inversión, lo hacemos invitando a los medios a que reconozcan la importancia del tema, invitando a los medios a que nos publiquen lo que estamos haciendo, invitando a los medios a que reconozcan. Entonces posicionamos el ITTC, pero además de eso estamos dando información clara y oportuna sobre la situación. Entonces ahí tenemos cómo la representación, cómo las noticias en los medios que hacían, atacar esas representaciones mentales. Decir en un medio de televisión que lo que estás haciendo está mal y te está haciendo daño, ¿cierto? ¿Por producto de qué? De la posibilidad de discutir esas prácticas, porque ya contábamos con una política. Y eso, esa estructura es más o menos la que hemos venido y a la que le hemos querido apostar. ¿Sí? Como ITTC, en la segunda gran experiencia tiene que ver con lo que se denominan intervenciones basadas en evidencia. Y las intervenciones basadas en evidencia tienen una tensión, y es que se hacen contraintuitivamente a lo que hemos históricamente hecho en tema de prevención. Nuevamente aparecen los modelos mentales en quienes hacemos intervención, que creemos que lo que hacemos está bien porque históricamente lo hemos hecho así. Entonces el ITTC aparece como un punto de quiebre a esas representaciones. ¿Man? Si estamos en la academia, si producimos conocimiento, si somos los encargados de hacer difusión de conocimiento basado en evidencia, pues nos toca entonces ir contraintuitivamente. Y ahí hicimos una relación muy fuerte con Plan Colombo y con todo lo que hemos visto acá, de todo lo que tiene que ver con los UPC y lo que eso significa a nivel de formación. Para cerrar, yo les diría que si algo hemos encontrado importante en este sistema de cambio, es centrar la atención en dos asuntos. El primer asunto tiene que ver con quién nos relacionamos y con quién nos conectamos. Y con quién nos relacionamos y con quién nos conectamos tiene que ver con a quién nos acercamos y a quién le hablamos. En colombiano sería a quién le hablamos al oído. Porque quien nos escuche es el que nos va a hacer la influencia de nuestra información. Y entonces aparece el asunto de que tenemos que potenciar lo que se denominó un comité asesor, donde vinculamos organizaciones privadas, organizaciones públicas y diferentes sectores. El reto que tenemos es que ese comité asesor tenga la misma identidad que nosotros. Porque mientras construimos esa identidad, estamos discutiendo que no estamos para contrarrestar y chocar con fuerzas. Estamos para todos trabajar en el mismo lado. Y ese ha sido uno de los retos que hemos tenido con el grupo y el que nos empuja a seguir trabajando con ellos. ¿Sí? ¿Y cómo lo hemos hecho? Volviendo los aliados. ¿Y cómo los hemos vuelto aliados? Permitiendo que sus ideas transiten por el ITTC. Entonces Naciones Unidas nos dice, me interesa que ustedes piensen todo lo que tiene que ver con inteligencia artificial y tratamiento. Entonces nosotros amplificamos la idea desde la universidad y colocamos el dispositivo tecnológico para pensarlo con ellos. Y ahí tenemos un aliado. Y ahí tenemos a Naciones Unidas diciéndonos, queremos estar más con ustedes. ¿Man? Con Plan Colombo integrando, iniciando su currículo universal en prevención. En ruralidad, nosotros nos acercamos y le decimos, nosotros podemos acompañarlos en procesos de investigación y sistematización. Nos dicen, claro, es un recurso que les suma a ellos, que les cualifica su producto, pero que nos fortalece a nosotros como ITTC. Entonces, esta es la primera parte muy fuerte que hemos venido trabajando, que creo yo que es fundamental. Y finalmente, la segunda tiene que ver con la punta de esa pirámide, la más implícita, y tiene que ver con cómo se reconstruye, se resignifica, se hace frente a las representaciones y a los modelos mentales. Hemos tenido unos lineamientos en política muy fuertes, unas transformaciones muy adecuadas a los contextos, pero posiblemente hay más voluntad política que incidencia a la hora de implementación. La pregunta no es hoy cuál es el enfoque, sino por qué no se implementa o por qué se está implementando de ciertas maneras. Y ahí aparece que para trabajar con quienes piensan en política hay que saber acercarse a ellos. ¿Ven? Y saber acercarse a ellos implica unas competencias y unas habilidades que la academia no está formada para eso. Entonces, tenemos unos comunicadores que nos están haciendo tarea de venta, marketing, cómo acercarnos. Un resultado es atractivo cuando tiene una prevalencia alta, pero él no necesita eso, él necesita saber cómo modifica eso para generar una adición política. Entonces, cuando pensamos en esos modelos mentales, en el orden del trabajo con ITTC y con otros sectores, el sector político, que es nuestro foco de interés, nos ha develado que necesitamos formación en habilidades y recursos para entrar a trabajar con ellos. Y nos puso finalmente a pensar, cuando la doctora Dedsy les decía que Colombia es multicultural, multiplural, multiregional, nos puso a pensar que si bien la política tiene enfoques diferenciales, enfoques poblacionales y territoriales que reconocen eso, es posible que mentalmente la hegemonía de quienes trabajamos en el campo todavía se siga sosteniendo de una manera muy uniformada o muy uniforme. Una de las tareas que tenemos también como ITTC es poder romper eso. Y para eso en este momento estamos desarrollando una investigación sobre barreras y oportunidades en la implementación, ya en la implementación en territorio en el país. Creo que esta semana para nosotros ha sido muy valiosa, porque cuando escuchamos a todos los ITTC conversar, así entendamos muy poco de lo que hablamos, sacamos todo el punto central, y es que nos encontramos perfectamente en eso que estamos haciendo. Y nos encontramos en que necesitamos trabajar en el diseño, en la planeación e implementación de las políticas, pero también centrados sobre una evidencia que nos permita ir en contra de la intuición, porque tenemos que generar cambios y como universidad cambios centrados en contexto. Muchas gracias.
Thank you so much. We might have time for a question. I know I have a question, but I don't know if anybody had a question. Sometimes we save them to the end, but I think it might be good, especially if some people have translation on now, to... Any questions? No? I had a couple of questions as I'm looking at the model. My first question was, out of the 6 conditions, you spoke about them. Is there one that was most challenging, or that you see institutionally for yourself, even applied to other ITTC activities, that will be most challenging for you? Number one. And my other question was follows on Cristobal's last comment about evidence, and if you have the capacity to do some of the evidence, some of the research on the outcomes from your vaping project or other projects.
Ah, entonces te pones... Bueno, básicamente creo que lo que encontramos en el ejercicio es que cuando iniciamos ITTC, iniciamos bajo la lógica de la importancia de las relaciones y las conexiones. Y ahí construimos el comité asesor. La clave del comité asesor era vincular diversos sectores y diversos profesionales y disciplinas. ¿Sí? Ahí tenemos un primer momento que fue muy fuerte y que fue con el que iniciamos. Sin embargo, si tú nos preguntas con el tiempo, hemos encontrado que los modelos mentales y las prácticas son de fuerte o de peso fuerte a la hora de trabajar. Y pueden ser incluso, si no se entienden bien, pueden ser las principales barreras para desarrollar las acciones. En ese orden de ideas, por ejemplo, con el vapeo, eran esas dos, la representación mental de que no hace daño y la práctica de que se puede hacer en cualquier parte. Y cuando llega la política, ataca esas dos representaciones. Y creo yo que la parte más importante es que el sistema es sistema porque es interdependiente, pero la parte más importante sería las dinámicas de poder. Y ahí era donde decíamos que es fundamental tener las herramientas y los recursos para poder hablar con esos representantes y grupos de influencia. Porque las dinámicas de poder, al fin, son las que terminan direccionando las políticas. Son las que terminan diciendo hacia dónde quieren apostar. Incluso nos hemos encontrado que a pesar de tener el recurso y la política, se hace inversión en otra cosa.
Great.
¿Sí? Vale.
Great, thank you so much. Thank you very much. Let's give them an extra round of applause. There's two of them there. Thank you so much. The next presenter will be Irina Pinchuk. Dr. Irina, I will pull up your slides now. Here we go. There we go. I've had the pleasure of working with Dr. Pinchuk for the last several years. Dr. Pinchuk is the director of the Institute of Psychiatry at the National University and president of the Association of Psychiatrists in Ukraine. And she's also the country director of the ITTC in Ukraine. She has served as an expert on mental health for the Ministry of Health in Ukraine since 2021. And from 2005 until 2009 and up till 2017, she was the chief psychiatrist and addiction psychiatrist of the Ministry of Health of Ukraine. She's had continued experience with clinical work with adults with mental health and substance use disorders, and has worked and organized the World Health Organization project on mobile community mental health teams, and has participated with the World Health Organization as a WHO consultant. So welcome. Great to have you here.
Thank you, Sherry, for introducing me. Good morning, dear colleagues. Yesterday, when we discussed about our progress and about our problem ITTC network, ITTC Thailand advised to ITTC Ukraine work with a military population and their families. Thank you very much for this advice, and today I will talk about our project, creating capacity to address wartime trauma in military veterans in Ukraine. Some words about our ITTC. ITTC Ukraine was established in 2020. and hosted in Ukraine, Kiev, Taras Shevchenko National University, and collaborate together with University of California in San Diego. Professor Igor Kutsenok is director of ITTC Ukraine. In my presentation, I will tell about why we decided to work with this project, some words about the background, then about the goal, objectives, our project system change, our first main activities, and aligning the project with the sixth condition. Background. 1/5 of Ukraine is under Russian occupation. Active hostilities have been ongoing since February 24, 2022. But the war started 10 years ago in 2014. For better understanding how we live in our country, I decided to show you a picture of the building of our university. This is our medicine faculty, psychology faculty after the Russian attacks, and the place near our main building, red building in the center of the Kiev. According data July 1st, 2022, this data provided by Ministry of Veterans Affairs of Ukraine. Near the million people, according to the law of Ukraine, have the status of war veterans. The largest number of veterans of the Russian-Ukrainian war belong at the age group 31-40 years old. It's 43.5%. The share of women among veterans is above 9%, and now we know it's more. There will be at least 4 million citizens who will be related to the veterans sphere, and this is very important for our project because in future at least 4 million citizens who will be related to the veteran sphere. According to the official register on November 19, 2023, the Commission on Established the Fact of Captivity announced more than 4,000 persons, and 763 among them civilian were found to be deprived of liberty. Out of these, 1,953 individuals were released from captivity. And these people also include persons who have been or continue to be held by the Russian Federation since 2014. We started our project at the end of the last year. The goal of the project is to establish a sustainable care system for combat veterans, especially those with a prison years or war experience. The primary objective is to implementation of the peer-to-peer principles in the system of care as a component of the comprehensive system of care, prevention, treatment, recovery support for the veterans in Ukraine. And the expected outcomes is a capable workforce addressing post-war trauma challenges, contributing to Ukrainians' national care system. About our main activities. The first our activity was a training for trainers in addressing psychological trauma in combat veterans and prisoners of war in Ukraine. 19 participants took part in this training. In this training, veterans, people who come back from captivity, representative from Ministry of Defense, from Ministry of Interior Affairs. This group of participants, our training was agreed upon with the management of the mental health coordination center of the Cabinet Ministry of Ukraine, and the aim of the training was disseminate the acquiring knowledge in different organizations which these people worked. And for us was very important that our mental health coordination center support this training, help us work with people, with organization will disseminate knowledge in future. The next, second, our important activities, monthly supervision for the third group to ensure sustainability and impact on system change. Every month we conducted this supervision. Every month we discuss about our progress, about dissemination, knowledge in organization about the problem. We had two specific meetings. We discuss about veteran spouse network, how to join to this network and help not only the veterans and work with their family. And for us was very interesting meeting when specialist mental health peer-to-peer from USA discuss with a future specialist peer-to-peer in Ukraine about this system. This was very interesting. The next, third, our main activity we decided was to visit to USA. This was higher level visit. This is the photo. Our group. Why it was very important for us? Because representative from different ministries, a department participate in this group. Representative from Ministry of Health, Ministry of Education and Science, the Ministry of Interior, the Ministry of Defense, representative two big university in Ukraine, Medical University and Academical University, National Guard of Ukraine, and representative from Coordination Center for Mental Health of Cabinet Ministry of Ukraine. Now all these ministries know about ITTC Ukraine, about our ideology and how we can help to change and develop the system in Ukraine. This was before our training 6 condition system change. Then we analyze our project after this training according to these 6 conditions: policies, practices, resources flows, relationship connection, power dynamic, and mental models. And what we got. Policies. When we discuss this condition, we discuss 5 points. First point, international cooperation, exchange of experience and transfer of best practices with other countries with similar problems. And we decided put plus or minus. Plus conditions which are supportive of our work, and minus conditions that may be interfering with progress. The next point, adapting legislation and international cooperation, we put plus because we decided that no, it's okay in Ukraine now. We have a lot of different partners, and we can continue these our activities. The next point, adapting legislation and policy. Developing and implementing legislation and policy to support veterans and provide them with appropriate protection and opportunities. We put plus on first place and minus because now a lot of different documents adopt our government, but it's not enough, and this work have to continue all time. The next point, networking and collaboration. Promote the creation of a network for organizations working with veterans to share experience, resources, and coordinate efforts. Also, we put on first place plus and minus because we started this work, but not enough. The next point, community and veteran engagement, including veterans in the development and implementation of program and initiative that support them, and mobilizing public support and understanding of veterans' issue. In this point, we discussed and decided that the first place minus, but we have a first step positive in this point, and the second place plus. The last point, legal advocacy and rights, ensuring that the rights of veterans and their family are protected, including access to legal assistance and fighting for social and economic rights. In this point, we also decided to put minus on first place. The next condition, practice. In this sphere we discuss 3 points, networking and collaboration, and plus and minus. Then research and implementation, support research and implementation to treat and rehabilitation war trauma and improve care war veterans. We discussed a long disposition and decided to put minus because we think this pay attention, this point now for Ukraine. The next, community and veteran engagement, also minus and plus. The next condition, resource flows, we discuss about 4 positions. The first, healthcare and rehabilitation, ensuring access to quality healthcare and rehabilitation for veterans with physical injuries, access to medical service, rehabilitation, and adaptive technologies. We discuss a lot this condition and decided the first place to put minus. We do a lot, but but when we now understand, after this training, we decided we can propose a lot and we can do a lot in this with this position. The next, international cooperation, I told about it. The third, social integration and support, providing veterans with social integration assistance, including vocational training, employment, and assistance in restoring social connections. For us, it was surprise. We put minus because earlier we didn't think about the social policy, and we understood that we didn't invite the representative from Ministry Social Policy to visit US, but now we think invite this ministry in our program. The next point, mental health support. Providing access to mental health services for veterans suffering from post-traumatic stress disorder, traumatic brain injury, substance use disorder, and other problems. This may include the creation of specialized centers and support program. We started work in this direction, but the first place minus, and I think this is the place where the ITTC Ukraine can help this program. The next condition, relationship and connection. This is repeat. We discuss 3 points: social integration and support minus, networking and collaboration plus and minus, community and veteran engagement plus and minus, and the next, power dynamic. 2 point, adapting legislation and policy plus and minus, community and veteran engagement plus and minus, and the last condition, mental models. We discuss 2 points. The first, education and awareness, conducting educational campaigns about war trauma and its consequences for society, reducing stigma and understanding veterans' problems. We do a lot, but after our discussion, we decided to put for first place minus. And we will work with this. And the second point, community and veteran engagement. And we received the such picture where all 6 conditions, all the point which we discuss for each condition, and in this point progress, dynamic, how we can work. We a lot of look this picture and decided organized 4 groups. The first group with plus, the second plus and minus, the third minus and plus, and the fourth minus. International cooperation now in Ukraine in the first place. We only continue this, but adapting legislation and policy, networking and collaboration in the second group. Maybe it's a group, if in our clinic we say about the group risk, different for group. The third group, community and veteran engagement, legal advocacy and rights, healthcare and rehabilitation, mental health support, education, and awareness. And the fourth group with minus research and implementation and social integration and support. We understand that our first step, we the first time have a plan. After the training, we change our plan, but I think this position, this plan will change when we will implement this model in the practice. And my last slide, we think about the role ITTC Ukraine in the system change. We understand that in Ukraine, ITTC Ukraine initiated this project in Ukraine, but now this project under the government, and this very big project. And we think about where our place and what our competition and activity, how we can help along building this system and Ukraine. And we I proposed some the key principle of system change are important to work of ITTC Ukraine. First, adaptability. The current environment is rapidly changing, and so it is important to remain flexible and adaptable in our approach. The next, experimentation. The system change model is currently theoretical for Ukraine team, requiring experimentation to evaluate its usefulness for ITTC Ukraine. And third, we decided to name the influence assessment. A crucial part of our work at ITTC Ukraine is assessing which part of system we can influence. And I think this part every time will change. Now we decided the such way. Thank you very much.
Great. Thank you, Dr. Irina. That was excellent. And great use of the model in breaking everything down. Very impressive. Thank you. I'm going to pull up, we can save our questions for the end. So if you have questions for Irina, we will wait. And until the end, I'd like to now introduce Dr. Kristiana. Dr. Kristiana is a medical doctor and also has her PhD. She is a leading psychiatrist in Indonesia, is the department chair of the Department of Psychiatry at University of Indonesia, and also works at Dr. Sipto General Hospital, working with addiction psychiatry and education research, clinical sectors, and much of her research focuses on substance and behavioral addictions. She's developed a questionnaire in Indonesians for young people with internet addiction. She ran a national survey for teenagers, young people with internet and substance use disorders or addiction in Indonesia. She has developed the module in addiction at the University of Indonesia, which is used for both undergraduates as well as the residency program. And she's currently organizing a one-stop service for patients with alcohol behavioral addictions and HIV/AIDS within the General Hospital. Besides giving advice to addiction policymakers in Indonesia, she enhances collaboration and networking with and between addiction centers around the world. So we're excited to have you, so welcome.
So good morning, everyone. Thank you for ITTC who already gave us ITTC Indonesia to share our work in our country, Indonesia, in this very important session. So I and my colleague, Dr. Eva, will share our work about IndoDARP. It's about Indonesia Drug Addiction Relapse Prevention Program, the effectiveness of telemedicine to prevent relapse among substance use disorder patients. Talking about substance use situation in Indonesia, now the prevalence issue of substance use disorder around 1.8% and now become 1.95%. So it's increasing. And most of them are male with comparison 18.5 compare 1 between male and female. But then we know that in Indonesia, we are low middle income country, so the human resources is limited. We have 17,000 archipelago in our country, and the human resources is lack to handle addiction treatment around our country. And also we are lack of unaffordable or inaccessible services in our country. So we have a big challenge that is lack of mental health professional who covering wide archipelago in our country. If we talk about 1.8%, it seems that it's a small number, but we remember that our population is around 250 million people. So 1.8% is quite big number for us. And in the right side, we can see that we are lack of human resources. So the psychiatrist is the front person who handle addiction treatment in our country. And we can see here the projected number of psychiatrists per 100 person in Indonesia currently at 1 comparison to 240,000 person. So it's very big gap in our country. And with that big problem, we think that system change needed to address this alarming issue in Indonesia. And one of the effective treatment of substance use disorder patient is to give cognitive behavioral therapy. And this is the schema. If we give a cognitive behavioral therapy, so we assess the trigger. This is Mr. Budi. Budi is a common name in our country. Mr. Budi, 30 years old and has an alcohol problem, drink beer a lot when isolating in his room. So the trigger when he is alone in a room. Then he thought that it will be fine if I drink alcohol, and there is a craving, intensive needed to drink alcohol, and then after that he get relapse. So CBT can change the mental model or cognitive errors in the person, and group CBT is very quite effective to change the mental model of the patient with substance use disorder, and they learn about how to cope with the triggers, how to cope with the craving, and prevent the relapse. And then we think that it's very good for us to give CBT or cognitive behavioral therapy for substance use disorder patient in our country. And then we adapted one module from Japan, Serigaya methamphetamine relapse prevention. So in Japan, they use this module for the patient with substance use disorder in the prison. And then we collaborate with Kyoto University and we adapted this module into our culture. So we need to develop community-based CBT program for substance use disorder in Indonesia. And we have participants, eligible participants, around 220 participants. And then we do the randomized control trial, and we have two groups. One group is intervention group that we give Indodarp module and therapy as usual. And then the other group is control group that the patient just get the therapy as usual program. And then we, from this research, we do the follow-up around 3 months, and then 6 months and 12 months. And in this module or in this research, we collaborate with many collaborators like general medicine or general practitioner, and also counselor and psychiatrist. So we can see here Indodarp promoted collaborative effort in addressing Indonesia challenge to contribute to substance use disorder patient or client wellness with no differentiation on who provided care, whether it's a psychiatrist, general practitioner, or counselor, as the focus all along is placed on the betterment of substance use disorder patient or client. So we include psychiatrist, GP, and peer counselor as a facilitator in this research. And then we adapt the module into Indonesian culture. For example, in the module, we write that religious places a safe place for not using drugs. So, and then we also include wudu. Wudu is the part of praying for Muslim to immediately stop thoughts about drugs. And also, end of Ramadan and Christmas, for example, of long holiday for precaution toward relapse. And then in the module, peer counselor from NGO emphasize the important many things. For example, ensuring client safety and comfort to discuss freely and honestly, developing internal motivation instead of forced external pressure, and implementing community-based approach or outpatient, not prison-like inpatient care, and valuing autonomy of clients to achieve abstinence or not with their own pace and methods. So we can see here from the system change, we have relationship and connection. This module provided substance use disorder client with a very safe and customizable space, not only strengthening through group therapy session, but also encouraging familial engagement in their own journey of recovery. And then we do pilot testing with the participant number is 9, and we assess what is the view or perspective of the participant. And they saw that there is satisfactory result. For feasibility, they said that it is very convenient to join from home, no wasted transportation time or cost, and good pacing between session. And also, they can able to open up personal matter. And counselor advice was impressive. And then learn new things like making daily schedule and risk of new substances, and felt others are very supporting. But also we have many challenging. For example, technological issue. So they feel frustrated with technical issue, and they need more time to share, because in one session we have just 2 hours every week. And at the end, from the pilot test, 3 out of participants prefer online than face-to-face meeting with increased retention at 3 months compared to therapy as usual. So the retention in IndoDAP group 80%, but the retention in therapy as usual or face-to-face group just 50%. So from this model, we can see that this result encourage system change in policy in Indonesia, that online delivery of care can be just as good as traditional face-to-face care with added benefit of adaptability and accessibility. And then we continue the research in 2022 to 2023, and for interim result, we have 79 participants across Indonesia who completed the program. And then we have 89% male, and median age is 39 years old. So the participant coming from many islands in Indonesia. And then with this model, we can see in system change, we have IndoDARP provided accessible and comfortable delivery of care for substance use disorder, aimed to remotivate or maintain their abstinence long after formal rehabilitation and therapy. And also from the system change model, online deliverance of IndoDARP also cut down the cost and time needed for substance use disorder client to reach the nearest healthcare facility, thus becoming a compelling resource-effective solution for substance use disorder in Indonesia. And this is the flow of our research. So we have eligibility participant 209, and then we should exclude 36 participants. So we can randomize around 120 participants and divide it into two groups, two intervention group, 60 participants, and the control group, therapy as usual group, only 60 participants. And then at the end, we analyze 37 in intervention group and 42 participants in therapy as usual group or control group. And this is the demographic data of the participant. So all participants, around 79 participants, 16% of them never receive any treatment of substance use disorder. And then the participant who already get the treatment, most of them for opioid substitution therapy like methadone maintenance treatment. And also 30% of them already got individual psychotherapy, but just 10% of them got group counseling. And this is from 79 participants, 18% of them ever receive online substance use disorder therapy, but most of them, 80% of them never receive online substance use therapy. And this is the primary drug of the participant. From all participants, 41% they use heroin. But then in intervention group, most of them also use heroin. Also in control group, therapy as usual group, most of them use heroin. But the second drug is methamphetamine, and the third drugs group is benzodiazepine. Benzodiazepine is quite high use in our country. And then we also assess number of arrests for drug charge. Almost half had been arrested for drug charge, and 16% was jailed 3 times or more. Almost 20% was imprisoned for 3 years or more, and the longest arrested was for 7 years. We also assess how many participants who finish all the program. So 29%, almost 30% finish all 12 sessions. 86% join more than half of all sessions, but 5% only join 3 or less. So this is our challenging, how to engage the participant to the program. And then we assess their abstinence from primary drug, past 12 days. And we can see here from the graphic, participants who receive Indodarp or in intervention group increased their abstinence by 8.2 days, significantly more than those who receive therapy as usual only, just 3.1 days, with a medium size effect. And we also assess days without craving or use of primary drug, and we can see here from the chart, participants who receive Indodarp or in intervention group increased their days without craving or use by 8.1 days, significantly more than those who receive therapy as usual only 1.8 days, with nearly large effect size. And we also assess the motivation or state of change of the participant. So we use Eureka or University of Rhode Island Change Assessment Questionnaire. And we can see here from all participants, most of them are in contemplation phase. But in intervention group, also most of them are in contemplation phase. But in therapy as usual group or control group, most of them are in action or maintenance. And we can see here, we stratified by stage of change using Eureka, days abstinent from primary drug, past 28 days. And then we can see here from the chart, control group has less improvement or even regress or decrease in abstinent days, particularly in person with action or maintenance state at baseline, while Indodarp or intervention group show improvement in all stages of change. So we can see here, the participant in control group, in therapy as usual group, although they are already in action phase, after the treatment, they decrease the motivation. But then the intervention group, for all the state of changes, they have increasing of motivation to change. And we also assess them by ASI, Addiction Severity Index, which has 7 domains. And we can see here, we divide it into medical, employment, alcohol use, drug use, legal, family or social, and psychiatric psychopathology. And from the chart, we can see here, psychiatric severity score, the last one, significantly reduced more among Indodap than control group. And other domain, except for family or social, also reduced slightly among Indodap group, but no statistically significant difference at this point. But Indodap or in intervention group, they have decreasing psychopathology of psychiatric symptom. And also we assess the other domain like quality of life, and then motivation, and the coping to handle the craving. And also we use as CL90R for assess psychopathology in the among participants. And then from this chart we can see we compare therapy as usual only group, that in this result we can see Indodap group or intervention group show better changes, slightly increases in quality of life, slightly increasing Eureka action state score, so they have higher motivation compared than control group, and decrease brief cop substance coping scale. It means that they have better coping to handle the trigger and the craving, and decrease psychopathology among Indodap group. So maybe they have like depression, but then the psychopathology is decreasing in Indodap group. So these have not reached a statistically significant difference at this point, but we can see the decreasing in Indodap group. And we also assess client satisfaction questionnaire. And then, for example, the question is, if you were to seek help again, would you come back to the same service? And then, Indodap participant had a higher satisfaction compared to those allocated in therapy as usual only. So they feel satisfied with the program. And this is my last slide. So if we apply the system change, so from the research or our program, we know that recovery is personalized journey, oftentimes riddled with sleep and relapse, and therefore it is important to maintain sustainable ecosystem of care, but not only acute settings, but the setting with nurture and supportive support system. And Indodap instill this value relentlessly to the provider and also the participant, that it is completely acceptable to seek for help anytime, and that sleep and relapse are part of the journey. So with this model, Indodap also help the changing the perception that online delivery of care is inferior to in-person therapy, particularly within the addiction field in Indonesia. Ensuring that high quality care may be provided regardless of place and time to reach those who need it the most. So with this model, we change the mental model, and we can change that to provide by online outcome is better than face-to-face program. And then our challenging is how to adapt this module nationally in our country. So this is the end of my presentation. Thank you for listening.
Thank you again to everyone. Let's give them all another big round of applause. We really appreciate all of your useful examples. We have a few minutes for questions. We have about 10 minutes. Any questions? Oh yeah, do you have any audience questions? I know I have one question for Irina. If there are no questions first, I'll ask mine. I thought you extensively applied the model with your positives and negatives, things that were, barriers or facilitators, pain points at each point. And of these 6 conditions, I felt you walked through it very thoroughly. And I'm curious with how applicable or useful was this exercise, and do you see yourself using it for other activities that the ITTC is doing in order to facilitate systems change? I guess my question is the investment that it takes to do as thorough of an application of the model that you did. Do you see yourself doing this repeatedly or using it more often? Or how might you use this model in other projects within the ITTC?
Thank you very much, Sherry, for very interesting questions. Of course, we think about it, and we don't think we see this is very useful for our activities and for our future plan. We clear understand and we our future system now when we in our hand we see these 6 conditions. For example, we all time now we think we have to work with policy, with the practices, very important mental models, because this is the new for us. For example, in our project, we discuss maybe we organize a social media company about the important mental health for veterans, for their family, for children, for consequences. Maybe we, in first time, will say about the substance use in veteran and their system. The social policy for us, the Minister of Social Policy, as I said, was surprised. Now we will invite the representative for this ministry in our project. And here, after discuss today's with network ITTC, we now saw that we haven't women prisoners of war in our group, and when we come back we invite for next our training the women with this experience, because for women we have to think about another system, another service, another ideology. A lot of change this training for us, first of all, for our plans, our project, and I think maybe for our government.
Great, thank you. Yes, Ziep and Bau. Mic's not working. Let's try your, Bao, you have a loud booming voice. How about you go first with your question and we'll see about getting and then Ziep can talk loud. Yes, go ahead. Great, thank you.
Thank you, Bao. So for the second question, not almost, all of them use a smartphone, not the laptop. So they can use everywhere because several of them are online driver, car or motorcycle. So they are working on that day and they can use smartphone to join the Zoom. So we have Zoom online platform. And that is the challenging for us because sometimes they don't have money and they then put the smartphone into the online debt, so they cannot use the smartphone anymore. But then they told us if they don't have smartphone, and then we borrow them the smartphone for the session. And when their smartphone already come back, so they can use their smartphone again. And the first question is about what model? Can you? Oh, okay. Yeah. The reason is because it's more accessible for online compared to offline. In our country, in Jakarta especially, many traffic jam in our country, and they usually live in the suburbs, so it is very difficult to go to the center of the city, and then they need a lot of money for transportation, so they prefer to use online, so they can, while working in everywhere, they can join the session. And then for the program, we also do obligation for them to show the face, not just the feed, not just the Zoom with no video. So the video in Zoom should be turned on. Thank you, Bao.
Thank you. Dr. Ziep.
Yeah, I think I share the same interest in the online system, the online intervention, and I see that the intervention model is quite effective, even in a short time, and it's have great potential for scale up. So my question is that when you think about scale up, like at a larger scale to train the system, what is the most challenges of the model? And I also share the experience when we do the Zoom intervention with women with HIV in Vietnam, and many of them share the concern about the confidentiality, because with the Zoom they have to find a private place that they can attend the session without any concern about their status. Thank you.
Yeah, so we have many challenging for this how to apply nationally, because with Zoom online platform, sometimes the participant can do the record with other smartphone. So we talk to them, please do not do the record. Because it's confidentiality, and what we have talked now is just around our group, not talk to anyone else outside of the group. But we still do not know they do the record or not. I mean, with the other gadget, so they can record what the other participant talks. So that's the challenging actually. And also about the gadget itself, sometimes they do not have the smartphone. Sometimes they cannot do the online, and most of them are not most of them, but several of them graduated from secondary level, so it's very quite difficult to use online. So the technical issue is very big for us, and our country has many rural area, and most of them cannot do the online, so technical support will be a big challenge. And the second challenge is how to advocate the Ministry of Health to use this program, online program, because They prefer to use offline to enhance the accessibility to go to the primary health care. But actually, this program can be done by primary health care, but by online, and they can come to the primary health care to take the medicine only. But the online Zoom can be done once a week without high transportation. Thank you. Thank you very much.
Great. I want to thank everyone. Thank you all for coming, and enjoy the rest of the closing of the conference and lunch. Thanks, everyone.